Now more than ever, patients are looking for immediacy and convenience in their healthcare. However, some people seeking mental health care are apprehensive when it comes to crossing the threshold of a mental care facility. There's a stigma that many people struggle to overcome, even if they could truly benefit from mental health services. The pandemic accelerated the way we view the role of digital health, and some organizations are finding innovative ways to beat the stigma by offering care to patients from the comfort of their own home. Casey Johnson is the CEO of HealthSource Integrated Solutions. He's been building out a teletherapy program for mental health care facilities across Kansas, and he's using tools like two-way texting and electronic forms to build a better patient experience. So Casey, great to meet you. Finally, I've actually heard for a number of months now a lot of really good things about you, and really excited to have this conversation. Certainly timely, as it probably has been for the past forever, but more importantly, in the last 12 months, I'm sure a lot of things have changed. So
happy to be here.
I'd love to kick it off with getting some of your background and how you got started down this path.
Well, so, I grew up, my father was a pastor. And so I think growing up, I always kind of had a passion or need to want to help people. And when I first left high school, I actually joined the Air Force and became and actually provided law enforcement for the Air Force. I thought that was the way I wanted to help people. But it very quickly became evident to me that I much preferred being proactive versus reactive. And so I left the Air Force and started to pursue a career in mental health. I got a bachelor's degree in sociology. And because I took a social problems class in maybe the first year that I was in school, and it really struck a nerve with me. And so I pursued sociology and then took a counseling psychology course towards the end of my bachelor's level career, and decided that I wanted to pursue my master's degree to become a therapist. So I trained and I have a master's of family psychology, and I thought that I wanted to be a therapist, and did a lot of different work in all the different levels. I started off as a direct care staff working at an adolescent residential treatment center for adolescent sexual offenders. I did community-based services where I did case management. And then about 10 years ago, I got offered the position to be a program director for a community-based service in Harrisburg, Pennsylvania. And it was there that I really discovered that, as a therapist, I could help a handful of people and improve their lives. But if I was a good administrator, a good leader, that I could greatly influence the care that a lot of people received. And so spent the last 10 years working progressively moving up into larger management positions within our large physical and mental health system on the East Coast, to where in the last 5 years, I was the service line director for our access and crisis intervention services. And so that's really where I developed a really high level of knowledge about the crisis industry and some of the kind of issues that plague it. The opportunity here at HealthSource came open, and I applied for it, and moved my family from Pennsylvania here to Kansas to take the helm here at HealthSource. And so on July 20th, I will be here for officially a year. So just enough time to get in, and but not probably don't know everything I need to know yet.
Interesting first year, I'm assuming, a little bit different than probably your predecessors.
Yeah, it's very interesting to move your family across country during a global pandemic. We were worried we weren't going to be able to sell our house, and we couldn't have a garage sale because of restrictions and that kind of stuff. But it worked out, and it's been interesting. HealthSource has several different kind of facets to it, but one of the most critical ones that we provide is a 24-hour crisis support service, to where we provide telephonic crisis support. And then we also do televideo support to people who are needing higher levels of mental health care. And so that's kind of a pandemic-proof business because there was lots of individuals that were still in crisis. And part of what helped us be successful is that we were already in the televideo space. And so we were able to quickly adapt to people working remotely. And we're able to continue to keep pace with the demands. And so it was an interesting year with a lot of different challenges, but it only made more clear how technology is really something that we need to continually look at. The pandemic forced us to move into televideo across the behavioral health field, which is something that in the behavioral health field we've been talking about for a decade. And so the amount of change, the rapid change that's happened in the last year because of the pandemic has been amazing. And to see how both consumers and therapists have adapted to it and adapted well has been pretty exciting.
Yeah, so I guess that strikes me as in contrast to kind of the historical use of technology in your space. Not only does it seem like we've gone from 0 to 60 overnight on the telehealth side of things, but I also feel like there's been this building, I guess, tech movement to address stigmatized health conditions over a period of time. And it's not just, it's not just mental health. It's companies like Roe and Hims and Hers dealing with other stigmatized conditions. When, I guess, the convergence of these all of these things feels like it kind of happened at the same time from my perspective. Is that kind of how you felt like it went down?
Yeah, well, I think, that's been part of the conversation that, there's always been this thought about if we could do things differently to reduce stigma. And we always knew that doing it in people's homes, providing it in their homes, so that they don't even have to walk across the threshold of our community mental health centers could greatly help and provide not only access, but also hopefully motivate people to get the care they need. But the wheels of change were very slow because most of the mental health services are provided by not-for-profit community mental health centers that don't necessarily have the resources to think innovatively. And you look at some of the organizations that are in the space doing mental health through televideo, they're all for-profit, and it's a company that says, hey, we can fill a niche, and you see how those organizations have grown exponentially because the mental health industry just was not keeping up with consumerism like it should because the resources weren't there.
Right.
Because of the pandemic, it forced that to where they were no longer saying, okay, well, we'll keep having people come to the building. They said, all right, let's get a Zoom license or we'll use Microsoft Teams and we'll start doing it via televideo and figure it out. And what will be interesting is to see, we've made a lot of progress, but all of it's in the back of our minds. I will also say the reimbursement in the mental health field has not been there. Our payers and insurance companies have not been willing to kind of pay at the same rates as they would for in-person services, and that's all changed with the pandemic.
Yeah.
It'll be interesting to see if, as we open back up and as we people think less and less about the pandemic. I don't know if it's over yet, but to see will some of those things that have helped move it forward be rolled back. Will we go back to where we're getting paid less for televideo, which will motivate people to shift back to in-person, or will it continue on? So that's something that we're watching and kind of being mindful over the next 6 months to a year. But I don't think there's going to be ever us fully returning to not having televideo as part of the mental health continuum.
Got it. And is that, as you think about reimbursement and what's changed over the past 18 months versus what's happening now and some states starting to roll back, is that a part of your strategy moving forward and in your expansion, looking at states and how they take into consideration the value of telehealth?
Yeah, I mean, Kansas is a very, it's an interesting state because it's an entire state of Kansas, there's 2.9 million people. So it's a big land area and people are very spread out. And so we think about our ability to provide services, and that's why, again, in a lot of ways, Kansas was ahead when it came to televideo out of necessity.
Yeah.
Where some of our, the cities or the states that are more populous, there's less of a motivation because people are more populous centers. So I think there's always going to be a need when we start thinking about rural and frontier care. But I don't want to lose sight of the fact that we have made it extremely convenient for people. And one of the things we saw that was interesting is that as we went to televideo, there was this perception at the start that people were just not going to be interested. And what we found is that there were fewer no-shows, there was better patient engagement because it was just easier. They could sit at home in their comfortable couch. They didn't have to go out and walk into a mental health facility. And so it'll be interesting to see, again, like I said, and we're thinking about that. HealthSource has always done televideo, so we're going to continue to do that. But the key piece would be for some of those areas where it wasn't in place, will we be able to keep it?
Right. That makes sense. And so I guess as you think about the separation between telehealth and in person and what we've learned over the past year and a half, what, we will talk, I've had conversations with telehealth experts in primary care and specialties and trying to kind of assess what's the true balance, the best possible balance between in-person and telehealth. And I know that we've kind of landed in this, if you think primary care, you're thinking more about 60% in person, 40% telehealth is maybe where we'll land, and it's just a hypothesis. But where do you think that balance is based on what you learned over the past 18 months?
Well, again, there's always going to be people who prefer to come in person. There's going to be people who are going to be slower to adopt it. It's been interesting because those individuals still use telehealth, and I think they appreciate it when it was there. But again, with mental health, it was before the pandemic, it was maybe like 2 or 3% tele versus the bulk of it happening here or in person. And so I think that we'll see a bigger split. What's interesting about this time is that it's also the therapists themselves who have gotten very used to doing teletherapy from their home. And so, you've seen all the different articles about this big mass resignation that
Sure.
For a lot of these therapists, they've grown very accustomed and found that it's worked really well. And so, I would say it'd probably be along the lines of 60 to 40. But one of the things that's different about the mental health field, and again, we can talk about this more, is just the crisis intervention piece. There's lots, the crisis intervention modality has been based on making a phone call for ages, and is not in large been updated to reflect kind of where people are and the way that people like to communicate now. So that to me is going to be as we move forward, how do we shift that paradigm?
Yeah, it's really interesting. I'm assuming that over the time that you've been in this field, you've dealt with everything from kind of along the spectrum of technology. As time goes on, you probably operated, I'm guessing, with very little technology for a really long period of time. What's the difference in the patient experience when you start thinking about what you just said around, I guess, the consumer adoption of tech and expectations for convenience that we all kind of live with every day? Like, how does that change the experience and ultimately, hopefully the outcomes? But what are your thoughts on how it's gotten better?
Well, if you look before, and still there's this case that if you in the state of Kansas, there's 26 different crisis hotlines based on where you live, and it's a 10-digit phone number. So the odds of people memorizing that or finding quick access to it are usually not good. So again, we've set up this system that's on very old technology. We've had the phone forever. And a lot of people, again, as we look at society now, most people don't even like making phone calls because we associate our phone with getting spam, or we associate it with things that are annoying. And so we
waiting on voicemail, or waiting on hold and leaving a voicemail.
Right. And so that's where we've shifted to this. I have a thought, I want to instantly send it to you, and then you need to instantly respond to it. Or even if you go and shop online, you have a little chat button that pops up that says, hey, can we help you? Yeah. And so looking at that to say, and there's been hesitation for the mental health industry to move to texting because, again, there's a level of anonymity that scares us, because when you're dealing with people in crisis who are suicidal, you want to be able to have them on the phone and, have law enforcement be able to go to where they're there and try to talk with them. And so there's a certain bit of trepidation to saying, well, let's try to do this through text. But there's been a lot of different advancements in geolocating and that type of stuff that you should be able to have a text with a person and be able to provide that safety. And the thing I think about is if we provide it in a way that is convenient, and you can have a text conversation that nobody knows you're saying. You can't do that with a phone conversation if there's other people in the room. And so you can access it more anonymously and get help, and more people would, in my opinion, would do it. And so that's, to me, where I would like to see the industry go, is to say, how do we get better at providing those services? And I also think about, there's lots of people that use technology like Google and Bing to say, how can I end my life? You know, if you look at the statistics, a lot of people that Google, you know, how to kill myself. And I think about, if we could do targeted ads for, if I say the word boot and it shows up, you know, could we do things like that, that if people are Googling that kind of stuff, to say, hey, let's get you connected with a counselor to try to change that outcome. So I think there's lots of opportunities. That might be a little bit big brother, but again, it's a way for us to think about getting people when they're at that place where they're at rock bottom and considering those things and saying, hey, there's an alternative and let's help you out.
I'm, first of all, absolutely blown away by what you just said, because it makes a lot of sense. And I think it's entirely doable. I think the big brother fear is, in this particular instance, hopefully less of a concern, right? I mean, it feels to me like that is an absolute no-brainer of a use case to find the people exactly where they are at the perfect moment to be able to intervene and help them. And technologically, like what you just described, is entirely doable. I actually think that's a conversation we should talk more about, because I think I'm in this business, and I've been in health IT for 20 years, and the software is really important, and the user experience and how we get this stuff done. It's all really important stuff. At the end of the day, we all have to be passionate about the problem that we're solving. And I believe so much in the work that you're doing, and the ability to leverage the newer technologies to solve it in a smarter way to help more people. And I think I would love to continue that particular conversation, because I think there's a real opportunity to reach more people.
Yeah, absolutely. Use that technology that gets such a bad rap for good. So.
Yeah, absolutely. I think there's a lot of good that could be done there. I think that's brilliant. So I guess one of the things you've been in operations, scaling a lot of the crisis line stuff. We've thought a lot about that consumer experience, or that patient experience of picking up the phone and wanting to talk to someone, real time, and then they're not there for 30 seconds, and that's the time window that you have. That's the patience that we have as consumers nowadays. I guess your thoughts on, now, after seeing it work and kind of knowing how people respond to it, the idea that asynchronous communication and having some, maybe not massive delays, but the ability to scale asynchronously versus trying to scale synchronous conversations. Yeah. They seem like they'd be very, very different things to try to scale. One, I think asynchronous being much easier to scale in theory. What are your thoughts on that, and how do patients receive asynchronous versus literally being on the phone with them?
Well, I think people would, again, it's a mixed bag. Of some people would hate it, but I think in large part people would appreciate it. When you think about it with our phones, if we have 5 crisis counselors on at any given time, and you have 5 callers, then that means that 6th caller is going to sit on hold, because you can only have one phone call with one person, and that to me is a big challenge. And oftentimes when you think about it, that person's calling at that moment, it could be really fleeting. And if there's any kind of resistance or barrier to that person getting in touch with somebody to get the help they need, they might just hang up the phone. And so in my opinion, that's really where, if we could be handling multiple conversations, you expand our ability to, work with people. I remember having an AOL instant, I'm going to date myself, but having an AOL instant messenger and having 5 conversations with 5 different people and being able to keep up with it. And we can do the same thing with crisis intervention. Yep. The other thing that is interesting to me too is, when you look at the crisis continuum, often you're involving law enforcement and medical professionals, because there has to be that care coordination. And so the same thing, they might give us a call to say, hey, we have a screen that we need to get done, or we have a patient that we need you to see, or we need an update on a bed board. And so then you'll have this nurse or this police officer that might be on hold. And when we're really hopping, it might be 15 minutes. So then we're taking law enforcement off the street. We're taking nurses away from providing vital care. And so if we could open it up to say, hey, why don't you just, we can text back and forth and have that conversation, then we can help them provide the services that they're designed to do more rapidly. And so it's just really about thinking about how do we make that continuum that's always been about using the phone, which is not the most efficient, and making it more efficient all around. And we've not started it yet, but we're getting there because again, it's a pretty new idea, at least in this area. But the response that we've gotten from people has been overwhelmingly, yes, let's try this, because I myself get very frustrated when I have to sit on hold for more than 30 seconds. And I'm not calling anybody with life-saving information.
Sure.
So if we could change that paradigm for professionals who can then in turn provide better patient care, then in my opinion, that's a big win.
Yeah, I think we all feel the waning, I guess, acceptance of or ability to be patient in these situations, because we know that there's something different, right? It's this story I tell all the time about how if my mom calls me right now, which is totally possible that it happens, but I'm not going to be able to answer because we've all got 1,000 things going on and we're in meetings and all of this stuff. But if she sends me a text message, the convenience for both of us is so much, kind of dramatically better, right. And easier to conduct that conversation. And then when you need to get on the phone, you can still coordinate getting on the phone. And so it's so simple, but it's really eye-opening for me to hear you talk about the impact it has in your space, because but there's a lot of nuance to it.
Right.
And I'm sure that it's taking a lot of time and just refinement to get it right. But it seems like, it seems like a perfect way to solve for some of probably the more challenging communication problems in the space.
Yeah, absolutely.
So as you kind of work down this path, and certainly in the last year and a half, like what, if you were talking to someone and giving them advice on how to think about kind of this paradigm shift, and I guess in light of the idea that not everyone's ready for it, this idea of using texting as a conduit for two-way conversation, you still get pushback on the idea. I'm sure you've felt it probably on both sides, on the clinician side and on the patient side. What are the biggest takeaways from the past year and a half on getting people on board, at least to start to experience what that's like? And then I guess the transition from how long does it take to get to that, once they're in there, feeling kind of what it feels like to change the way they communicate, to the point where they're like, light bulb goes off, they see it. Is that, what does that kind of look like from your observation?
Well, I think more than we think. Again, they've never had an option. It's always been call this crisis line, and even there's a new federal initiative to make 988 as a nationwide 3-digit number to get connected to a crisis phone line. So we're still pushing the same narrative about pick up the phone and call. Yeah. And I think that people will do that, and that'll make it more convenient. But if we can say pick up the phone and text, or jump on this website and get connected with somebody, or and there are some things like in Utah, there's the Safe UT app that is an app that was developed by the University of Utah, I believe, that allows teens to text with clinicians and to say to submit tips, and it's been pretty amazing. So I think there's instances out there where people have been really innovative, and you're seeing really good results. And I think that people are ready for it. The industry has just been slow to do it. And even with texting, there's still that kind of hesitancy. But I think once you open the floodgates, there's still going to be those people that want to call, but it's going to be far less. Yeah. And we're going to see that more people are going to get reached, and more people are going to access it because they can. But then also the workforce, in my opinion, will be better able to manage it, because instead of being on the phone for 10 or 15 minutes with one person, maybe you've had 5 conversations, And again, part of the things that I like about OMD is that we can use some of those canned response to save times for people, and to think about how do we, craft a crisis conversation using those things. What will be interesting is with the advent of AI, is if we could get to the point where giving it that kind of protocol to have somebody text in and have that natural kind of conversation and be able to do that with use of an AI versus a person. I think that'll be interesting. That's not tomorrow, but we'll get there too.
I think a lot about that. I think I would love to get your thoughts on my perspective here. I think there's a role for it, without a doubt. There's a role for beginning to use automation in the context of a conversation like this. And patients are smart, right, and people are smart, right? And so we know the AI is not ready, and I think it's going to be a while.
But AI is too quick to respond.
Yeah, I mean, I also the dynamic. It's very complicated. It feels very simple. I've watched companies in health tech that have been building AI bots for 10 years, right. And I still have yet to see a true interaction that feels human. And I don't know that we're going to necessarily get there anytime too soon, but I think there's a balance, right? Like, what can we automate as a part of this process to keep people engaged, to get some of the answers early on, or to collect the information needed to put them in touch with the right person, and build on that, and also, incorporate the human connection with a real human until the AI is actually smart enough to be able to conduct some of these things and be trusted. And I think that's like the trust word, two words that come to mind in healthcare: trust and empathy.
Yeah.
Specifically in your space, I think are both really important, but I think generally in healthcare are super important. So I guess that it's going to be a balance until then, and super interested in your perspective on all that.
Well, it would be, again, I've always said that you would never be able to get away from having a person in mental health. Yeah. But again, that doesn't mean you can't have an AI start 5 conversations that are monitored and then allow somebody to jump in and that kind of stuff. I think that there, like you said, there's a role for it, but it would be really important to be conscientious that you're right, people will pick it up. When you're speaking to a bot versus a person, because of just those human things we do and how long it takes for a person to reply and that kind of stuff. So
yeah, absolutely. I think it's I think we're solving the right problems in the right order.
Yeah.
Right. And I'm going to misquote the specific data point here. Somebody sent me an article from yesterday, a study just showing that the number one concern for patients right now is ease of access to healthcare. And I think that has come, kind of downstream from COVID. We realized that there is an easier, more convenient way to access care that we didn't really ever see before. And I think it was, 7% of patients had ever done a telehealth visit before COVID. And now, we've reached a point where like 40% of Americans have at least had a visit through telehealth. So I think, opening the doors, making it easy for people, eliminating friction from the first message that they send is the most important, way to open the door. And then as we learn more, hopefully we can begin to do it more efficiently and even better.
Well, it's interesting you talk about that. As I've, HealthSource, we are an administrative service organization that supports the community mental health centers in Kansas. And there's 26 of them. And several of our centers have purchased OhMD to use to kind of try to think about how do they get patients started. Because we ran into this conundrum that we shut down our buildings, and how do we get all that necessary paperwork that we have to do to make sure we can get bills out the door completed. And so we were mailing it to patients and sending it back. But when I've talked with them and kind of helped them cast a vision for something like OhMD, it's always been from the perspective of what would it look like if a person never had to set foot through our door. And that's a new concept for the community mental health centers, that the foundation has been, if you want services, you come to our building, You sit down, you're going to fill out 15 to 30 minutes of paperwork, and then you're going to meet with the therapist that's going to form your initial treatment plan. And all of that requires them sometimes to take off work or to, come in when it's not convenient, or there's stigma related to, everybody knows that's community mental health center. Now you're going to get mental health services. And so using this, a product of OhMD to not only communicate with patients, but then also use the forms to say, hey, we can embed it in the website to say, you don't ever have to set foot in this, just fill this out, and we'll get you connected with a therapist, has provided a lot of access to people who might have just said, it's not worth the trouble. And so I think that that's the kind of thing that I'd like for us to continue to do, is to say, how do we make that and continue that? Because I think that people will respond well to it. And if they decide, hey, you know what, I want to come in, great, then we can ship. But how do we reduce the barriers and make it, there are always going to be those things we have to do because we are billing state and federal funding. But how do we make that as less onerous as possible?
Yeah, that makes sense. I mean, it was as everyone knows from the past year and a half, it was the perfect storm of mental health challenges for basically everyone, and not being able to go anywhere physically.
Right.
So obviously, you and your team were in the right place and solving the problems in the right way. But I'm super curious about how it expanded your reach. Maybe whether that's a number of patients served, or in any other way. It's just such an incredible challenge to be faced with, and a really important one.
Well, and it's we're still in the infancy. Again, talk about where the people for the first 6-7 months of the pandemic, people were super innovative. And I think that they reached a point where they're like, oh my gosh, I'm so tired of being innovative. Yeah. And then we started talking about bringing on OhMD. And so some of our centers, they're excited about it. They have the vision, but then again, their capacity to be innovative and to kind of change processes has kept them from fully embracing it. So my hope is that over the next year, as we, because again, this is not as the world opens back up. There's things that we need to continue to bring with us to say we want to keep this. There's some things we should say, well, we did this temporarily, but it doesn't work. But I think that this will give us that opportunity to provide that expanded reach, especially to our rural folks. We have a CMHC that is in the western part of Kansas that covers an area the size of Connecticut. And but in that space, you have very, very few people. And so they're very used to driving far distances. But if we could go and say, we're going to be able to expand this in a rural and frontier areas using this product, I think it's going to be amazing.
Yeah, without a doubt. I think you're absolutely right. It's a lot for me to think about. We have so many things to learn about what's possible here. I think we're just scratching the surface. And we talk a lot about OhMD as the conduit to reaching the patient. But how else can you use that conduit to deliver better patient care? And it doesn't necessarily mean that it's all remote. Like I said, I think the balance here, and I think what we really care about is finding that in-person to telehealth balance where you can be seen by the same care team in both places. Yeah. And I think that's what excites me the most about the future is, having done a pure direct-to-consumer telehealth visit where I had a sinus infection, and then realizing that person knows nothing about me, that doctor is someone I will never see again, and also the information that doctor learned about me will never reach my primary care doctor. It doesn't feel like the best way to do this. So I think the future requires these types of innovative solutions to solving for the connection between pure telehealth and brick and mortar.
Well, one of the things that's interesting to me about this is that, again, I mentioned that I've done things, and when I think about how this could impact, I agree with you completely that it shouldn't be, here's your telehealth visit, and it's completely separate from your care continuum. And I think that, when you think about our providers our outpatient therapist will see you, once or twice a week, depending on what's going on. And if you call in, typically they're in a session, so they can't get back to you. But who's to say that, like you mentioned before, that maybe they could send a quick message or something. But also, we do a lot of community-based services where we have case managers who are driving around the communities and seeing people's in homes and schools and that kind of stuff. And being able to text with patients. For example, when I always think about how this could have helped me in my career, but I'll never forget going to see a patient, going to their house and knocking on the door and waiting the requisite 15 minutes for them not to open. And then drove back to the office and called them, and they said, "Oh, I was at the neighbor's house." And I said, "How great would it have been for me to have OhMD to text that patient to say, hey, we're here, let's meet," and then I would have been able to provide that service. And so I think that there's the televideo, but just also the ease of communication, and that's the preferred by most of our consumers is to text. But we also don't want to give out, there's those professional boundaries where I don't want to give out my personal cell phone number because then that erodes those boundaries. But if I could use the app and turn it off and on and turn off notifications, then they can text me all I want, and they can get on there and address it when I'm available and that kind of stuff. So I think there's lots of implications for that, to just do that ongoing care navigation. Not even just hey, let's do a video visit, but to keep them engaged in treatment by ongoing communication. And instead of handing a brochure and saying, hey, take this home, and for it to get stuck in the seats, to say, hey, I'm going to text you a brochure about deep breathing or relaxation skills that will help you with your anxiety. There's a lot of opportunity there that we're just scratching the surface right now.
Yeah, you talk about things in a lot of the same ways that I think about them. The brochure we leave in our car, the second someone hands it to us and we never look at it again. How can we use this conduit to accomplish a better transfer of knowledge from the care to the patient?
Well, and how many times have you gone back to a text message to find that picture that somebody sent you, and it's still there? So,
yeah.
You can always go back and find it, unless you delete all your text messages, which nobody ever does.
Yeah, no, absolutely. I always go back to learnings kind of along this entrepreneurial path I've taken for so many years. And one of the earliest conversations I had about OhMD was with a big health system in New York City. And I remember talking to a physician who said to me, I don't want to use this because texting is really impersonal. And this was, I want to say 2014, 2015. And I think what's hard for a lot of physicians and other clinicians in the space is to realize what it's truly like to be a patient.
Right.
And what's impersonal isn't texting. What's impersonal is what they have to go through every day that they're not communicating.
It's sitting on hold for 15 minutes waiting to talk to your provider. That's impersonal.
Absolutely. That's impersonal, right? And it's hard. And I think, that was, again, six plus years ago. The world has changed. I'm sure if I talked to that physician again, maybe she would have a different perspective on it. But it's interesting how many kind of obstacles to what I feel like is just, yes, it's such a simple solution. All we have to do is look outside of healthcare for a minute to see how people are using technology and how we can eliminate friction in this process that is more important than a lot of the places texting is being used. I love it when my auto dealer sends me a message that says, hey, your car is ready to go. Come on and pick it up. I love that. What'd be even better is if this conversation is happening in a way that really impacts me personally and my health and the way I feel, and all of the other things that go along with healthcare that we want, and we know that hinge on good communication. So I think you and I are on the same page on a lot of this stuff.
Absolutely. Well, it'll be interesting to do a look back in 6 years to see if we've made significant changes or if we're still on the phone.
Yeah, we'll see. I had somebody ask me recently, well, Ethan, you're building this thing, or you built this thing around texting. What happens when the next technology comes up? Are you going to be able to solve for that? And we just started kind of spitballing about what does that mean? I think at the end of the day, could it be voice through Alexa? Yeah, it can and it could be. But I think regardless of the actual technology application, we know it's going to have to be more simple to use than texting. frictionless wherever possible, and then we'll continue to kind of adapt to what we learn outside of healthcare, because we know healthcare is not often leading the charge on technology. So we got to look outside the vertical.
Absolutely.
All right. So last question, and this is really for people going through this this evolution of change, this the technology innovation that they've had to kind of be forced to go through over the past year and a half now. What would you have done differently as you look back at the last year and a half and kind of take into account what worked and what didn't? Is there something you would point out as like, really, you got to think about this thing before you go down this path?
I always joke that I wish I would have invested in Zoom before the pandemic, because
yeah, I'd say like 2020 on that one for
right,
sure.
Yeah, it's kind of like it's become synonymous with video chats. We don't say we're going to have a video chat, we're going to Zoom, even if you're using something like Teams or something. But I think I don't know if there would be anything that we do differently. Again, I think what's interesting to me is all of this stuff is stuff we've been talking about for years, and there just was never that motivation. And so think about how different this would have been had the payers been more willing to say, yeah, this is the wave of the future, or mental health centers said, hey, how do we get this going? I mean, I think that was such a challenge. And when you think about that gap, that there's a gap where as we are shifting, did we miss people or that kind of stuff? And so we were not prepared, and we adapted quickly, which is phenomenal. I mean, the level of innovation that happened in mental health in the last year was extraordinary. But again, I wish it's something we'd always been talked about. Every single conference you would go to, people talk about telehealth and wearables and all that kind of stuff. And so my hope is that we don't go backwards, and that we continue to be innovative. Again, just even like using text, we're still not even there. And I think that would be a huge addition, and our patients would appreciate it and value it.
And hopefully the patients are the ones driving this change. We aren't, if we leave it up to the insurers to drive change, then we're going to stagnate, and right. Nothing's really going to change. So I think hopefully what the patients have experienced in the past year and a half has given them insight, and many of them have given them insight into what it could be, right? And I think that statistic I gave, that on-source statistic of 87% of patients have said that that access to care and convenience for that care is most important to them. I think that probably represents the change that they're going to drive in the coming years. I hope so.
Yeah, absolutely.
Well, Casey, this has been a pleasure. I absolutely love what you're doing, and I appreciate it. You and your team, kudos to you guys for the work that you do. Really important, and I'm so happy that we're partners in doing this. And thanks so much for taking the time.